Thank you, Dr. Jeevan and Dr. Amit Goel for this opportunity, and good morning, chairpersons, Dr. Chaudhary, who's been my teacher as well. My topic is non-alcoholic fatty liver disease in children. How big a problem is it? And I'll take you through what we think about it. The word alcohol bothers me, especially in children. It's a stigma for us in pediatrics. So we'd rather call it pediatric fatty liver disease. Whether you call it NAFLD or baffled, the debate is ongoing, as we've heard, but I'm frankly baffled, just like you are in adults. But for me, the MAFLD is actually the steatosis of inherited metabolic disorders that tends to mimic actually the NAFLD that you see regularly in adults. And these are various settings, those with acute liver failure, infantile jaundice, organomegaly, development delay, and those patients who are incidentally detected, they all have some kind of genetic metabolic diseases. And this is the real MAFLD for us. Then you have this third group, which is the miscellaneous group, which is systemic diseases, drugs, photosystemic shunts, hepatitis C, and so many other things. So there are fine lines that differentiate between the three. Now, the reason why I'm saying is it's important is that there are so many conditions in children which are metabolic, like hereditary fructose intolerance, Wilson's, Gaucher's, GSD, and so many things that persist into adulthood. And you would see it perfectly as NASH. And there's some who are presenting in adults for the first time. And when you go back to their childhood, you find that there are family histories of SIP deaths and consanguinity, dietary aversions or cravings, or some kind of a past history that's bothersome, that will actually tell you that these patients are not really non-alcoholic fatty liver disease. They probably have some other disease in the background. Now, this is a huge different topic, and we won't go to the same. Coming to the main topic of our interest today, what is the global burden of pediatric fatty liver disease? If you look at this slide, and this slide will tell you almost everything, that the Hispanic population in South America is probably about the highest incidence, just like you have in adults. And the overall percentage of prevalence of this is approximately 3 to 10%, and mostly in the developing countries. But most of them have screened with ultrasound and the ALT levels. Very few have looked at transient elastography, liver biopsy, or MR imaging. What is the burden in India? If you look at the urban school-based population in Mumbai, 32% of their patients were obese, and 62 patients of these patients had NAFLD. When they screened obese children in Pondicherry, they found 50% have NAFLD, and their lipid profiles and the insulin resistance did not change between the two groups. When they looked at rural obese patients in Punjab, they saw that 63%, about 2/3, were already having NAFLD, and they had a higher waist circumference. What are the factors that cause surge in pediatric NAFLD? And number one would be the diet. It's not the carbohydrate anymore. It's the ultra-processed foods that are going to cause you more of this condition. Obesogenic diets and increasing exposure to addictions. Activity, which is less, rapid urbanization, and there are definitely genetic factors that are playing in the background. And these genetic factors are the standard ones that you're seeing in adults as well. There are some which are protective, and there are some which are predisposing. So all these have a major interplay. This is a very interesting article in Lancet that has come last year. And Dr. Bernadette Moore talks about how the COVID pandemic has affected pediatric NAFLD. And this is a national child measurement program in the UK, where at reception, that means at 1 year of age, the class 1, they had 10% prevalence. And by 2020, after the COVID, the prevalence is 14%. Final year students, 17.5% before COVID and 25% after COVID. So in UK, the most deprived areas and the poverty-stricken areas had increasing NAFLD, and this is very different from us. The most deprived area there did not have access to expensive, healthy food. And you have to remember, food which is healthy nowadays are expensive. The lockdowns brought down the playtime, increased the screen addiction, and those of us who have smaller children would realize that post-COVID pandemic, to de-addict these children from screen time was extremely difficult. They had an obesogenic food environment, and there were obviously lifestyle stresses. The parental job had insecurities during the COVID times. Are the children symptomatic? Yes. We usually see our children between 11 to 13 years. Most are found on screening. So 1/3 on obesity. They have insulin resistance, metabolic syndrome, and sleep apnea. Vague symptoms are debatable in children. Some people say they agree that epigastric discomfort is a part of NAFLD. Some do not agree. Fatigue, headache, hepatomegaly is seen in almost 50%, and acanthosis nigricans in about 33 to 50% of biopsy-proven NAFLD. So the actual prevalence of this condition in our community is very difficult to assess because a niche group of patients are only coming to you. What I see here, I see very little of NAFLD. The ones that I do pick up having NAFLD are actually those patients coming to us with functional gastrointestinal disorders, and they have a fatty liver, an ultrasound, or a mild transaminitis. What is the natural history? There's a paucity of studies, but what we know is the rate of progression, fibrosis progression in children is 9 years per stage. So that means if a child is having stage 2 fibrosis at 12 years, we're expecting cirrhosis probably by 40 years if the risk factors are going to persist. But here's a catch. During adolescence, these patients either have a rapid weight loss or a rapid weight gain, and that changes the outcome. So in children, the natural history is not as steadfast as you see in adults. 22 to 25% show a quick progression over time, and 50% may actually show resolution. Less than 10% require liver transplant in childhood, and the onset of type 2 diabetes mellitus, which is very rare in children, is the earliest comorbidity, but 3.5% almost develop by the first year of the diagnosis. And obviously, patients who have dyslipidemia and hypertension have higher progression. This is a very key question that is there in children. Can we avoid liver biopsy? Now, there's a huge confusion to this. In children, the problem is that, number one, they take gender-specific ALT levels in US, but Canada says, let's look at age-specific ALT levels. So there's a confusion there. What is to be done in India? We don't know. Ultrasound can only pick up 33% steatosis and above in the pediatric liver, so it's not a good tool. And alternatively, MRI or MRS is an upcoming modality in children. Overall, there's a reluctance for biopsy. It's fraught with complications, especially in an obese patient. Biopsy remains gold standard, especially for staging. And the North American Society of Pediatric Gastroenterology in 2007 has brought about guidelines as to when we should do it. Now let's look at these guidelines as a gist. They say you screen for those patients with gender-specific upper limits of ALT, and they do not recommend ultrasonography as the first modality. The workup of a suspected NAFLD patient, if you want to do liver biopsy, and for the workup, you should actually be ruling out all the metabolic conditions that I had shown you on the first slide. That becomes very, very important for us. And when to consider liver biopsy is those patients who have selectively, who have an ALT level more than 80, have splenomegaly, anything to suggest there's cirrhosis, AST-ALT ratio is altered, and if they have known risk factors such as panhypopituitarism or type 2 diabetes mellitus. ASLD, on the other hand, plays safe. They do not really recommend biopsy in children, and they leave it up to you, and they say only if your diagnosis is unclear. But what ASLD also says, they would agree, is that before you diagnose NAFLD in children, you should have taken care and realized that there is no metabolic liver disease in the background. Can we narrow down the biopsy indication even further? Yes. There are pediatric NAFLD indices where they take the age, weight, circumference, and the triglyceride level. It has a good positive predictive value, but a poor negative predictive value. And any level less than 3 excludes and more than 3 indicates. Anywhere between 3 and 9, then they use one more test, which is all in the research tool, which is metalloproteases, collagen, and hyaluronic acid. And with the combination of these two fibrotic factors, they can probably diagnose in 84% of the patients. Can we predict steatohepatitis in children? Not very good. Based on the apoptosis concept, the CK18 has been used even in children, but they have said it's not very accurate. They've used cytokine levels. The results are not consistent, and they are not reproducible. This is a nice FibroScan-based study, and these are a very nice longitudinal cohort in the UK, where they have started screening these patients, and at the age of 24 years, they found that 1 in 5 young people had steatosis and 1 in 40 had fibrosis. And the risk of fibrosis appears to be highest in those patients who have harmful drinking patterns and steatosis. This is a very, very nice, one more very nice study that has come in Journal of Pediatrics recently. And again, this is a longitudinal cohort. This is called the EPOCH cohort, and this is a 604 mother-child pair in USA. And one of their objectives was to look at hepatic fat at 2 points of time. One visit was at 6 to 12 years of age, and the second visit was at 12 to 9 years of age. And they diagnosed NAFLD as more than 5.5% on MRI. And then they asked this one fundamental question: what diet is best for your children? It's something every pediatrician would ask, every mother would ask the pediatrician. And they found that increasing fiber, vegetable protein, and PUFA from childhood to adolescent was associated with lower adolescent fat, whereas increasing animal protein was associated with higher fat. The PNPLA3 risk allele had an interplay in this diet business. In conclusion, they said, you have to have better fiber and more vegetable proteins in your diet if you do not want NAFLD in children. What is the therapy in children? Not many options. Just like in adults, you have better options, I think, in adults. But the only thing that we can probably talk about is this particular paper, which looks at how much body mass index to actually bring down in NAFLD. And they say that if you could bring down the BMI score to a Z score of 0.27 in 90 days, then probably you would achieve better ALT levels. And the better performance in these groups were the young age patients and those who were non-Hispanic in origin. This is the famous TONIC trial, which we can talk about, the only one in its pediatric series. It's a double-blind, placebo-controlled trial that came out long, long ago in 2011, I think. And they used a high dose of vitamin E and metformin, and they showed that NASH resolution occurs in 58% of the patients. And they showed significant histology improvement, and those patients who were only on metformin did not show much of improvement. So they say high vitamin E is good, but adults would differ, I know, because high vitamin E in adults is associated with prostate cancers and stroke. Role of adjuvants, very poor in children. So we have only as a part of personalized medicine. Probiotics is a no-no. Now I want to bring this last part to you, and that is cholesterol ester storage disease, which is also known as the lysosomal acid lipase deficiency. This has a significant overlap with NASH or NAFLD, and these are two very nice review articles, one from BJ Chandigarh itself, which has looked at this progressive reduction of the LAL, the lysosomal acid lipase deficiency in patients from all the way from NAFLD all the way down to the most lethal condition, which is known as Woolman's disease, which we see in children, and also cholesterol ester storage disease. These are the two very important diseases in children. And this is probably a huge spectrum of lysosomal acid lipase. So who to measure the LAL activity? The clinical situations to suspect CESD in pediatric population is the lean NASH. So all the adults who talk about lean NASH, we in children in pediatrics would probably say, well, have you ruled out CESD as one of the primary conditions? Obese patients who are not showing any improvement to their body mass reduction. Adolescents who are diagnosed with NASH but have a liver biopsy was showing microvascular steatosis. And a NAFLD less than 5 years of age is very, very unlikely. And pediatric nephrogenic cirrhosis are all the indications where you should be measuring the LAL activity. So I come to in conclusions, the primary question that the organizers ask me: how big of a problem is it in children? It's exponentially growing. What we're doing to our children, I can't imagine, but our children are growing fat and so is their liver. There are epigenic factors which are overwhelming the genetic issues. There is overlap with metabolic liver diseases, especially in children, and there's an unpredictable natural history. And looking at the liver outcome is only a tubular vision, and I can probably agree time and again with Dr. S.P. Singh, who had shown that big elephant. And if you look at only the liver outcome, then it's a very tubular vision. There is a reluctance for biopsy, no doubt, both for the parent, the child, as well as for the physician. The other diagnostic modalities are a fallacy. These patients have dynamic growth, career issues, so their compliance to lifestyle and diet is going to be a major issue all throughout. And there are not much options in pharmacotherapy. With this, I thank you, and I ask you the key future question: how can we actually prevent it in children? Thank you. to the organizers, Professor Bhiman, Dr. Amit Goel.